Hi again. Today we're going to talk about depression. Is treating the gut a new frontier in antidepressant therapy? I'm Dr. Martin Rutherford. I am a functional medicine practitioner here in Reno, Nevada. I've been a chiropractor since 1979 with certain aspects of my practice leaning towards nutrition for many years, but now I practice primarily functional medicine. This is my colleague and partner here in crime,
Dr. Randall Gates. I'm a board-certified chiropractic neurologist as well as being a chiropractor.
And these are two disparate and seemingly different disciplines that we have crunched together, but the reality is these disciplines overlap substantially in that Dr. Gates's discipline is relative to primarily brain function, but inevitably all of the nutritional aspects, all the biochemical aspects and metabolic aspects and hormonal aspects that affect brain function. And all of those aspects are really kind of encompassed and defined functional medicine, which is what I do. So we have munched these two disciplines together and have developed a chronic pain practice in which we treat fibromyalgia and peripheral neuropathy and chronic fatigue. And if you want to know what we treat, you can look on our website. But lots of those types of things, a ton of neurological problems. In fact, I'd say we're morphing towards primarily neurologic problems, chronic conditions with neurological components. And in doing so, we have had the great opportunity to observe a lot of things. For example, boy, my tongue is tied today. For example, the fact that almost virtually every person that comes here with a long-standing chronic pain, or frankly, even a short-standing chronic pain, experiences depression. Mm-hmm. It's rare that I read one of the intake forms and the person doesn't have depression. And I just reviewed, as I do. I've taken to the habit of reviewing the Mayo Clinic to today's information on whatever we're dealing about, because everybody says, well, how come my doctor doesn't know about this? And then I can say, well, the Mayo Clinic doesn't know about it. Then why should your doctor know about it? And I'm not bagging the Mayo Clinic in toto. It's just that for chronic pain, that's still not their model yet. And as of this morning, the Mayo Clinic says, well, we don't know exactly what causes depression. That's quote. I'll quote it exactly. Cause of depression is not exactly known. We think there are biological differences in people. We think there are hormonal problems, which we might touch on as a secondary aspect to everything we're going to talk about. We think there are inherited traits. We think there are life events. This is not what causes depression in general. These are kind of what I call like pseudo-neuropathies. These are kind of pseudo causes of depression. There's so much literature out there on things such as blood sugar and inflammation. And Dr. Gates, I think in the functional brain world, it might be accurate to say that functional neurologists kind of think of depression simply as a frontal lobe abnormality, not firing right. There's a lot of things that cause depression that aren't exotic. But we're going to talk about the gut today, because a lot of the things that I would list here are corrected or balanced once the gut function is stabilized. There are traditional Eastern models that would say fire in the gut, fire in the brain, fire in the brain, fire in the gut. A lot of people now come into me on the consult and say, gut is the second brain, and things of these nature. So there is now a growing understanding, even outside of the research community, but apparently not in Mayo Clinic yet, that the gut may have a lot to do with it. In fact, I was going to talk about the obesity thing. In fact, when you came here and I wrote that article on obesity, and why are you writing an article on obesity? I said, who comes here and doesn't lose weight? And Doug gave us wow, that's right. And so now we have people who come in here who can't lose weight, really can't lose weight. It's the same thing with depression.
Mm-hmm.
I mean, very rarely does somebody leave here still
Right.
with depression.
Right.
And we're not treating people for depression.
Exactly.
So that's kind of the lead in. That's kind of the overview.
And we know that can be controversial too, because for those suffering with depression out there, they're looking online, they're talking to their doctor is telling you, you know, it could be genetic, as you said, it's genetic, it's environmental, you went through a divorce, you know, you saw somebody die. These are obviously horrific circumstances that can predispose somebody to depression. But there is also the case, well, there are a lot of people who go through those types of circumstances who don't become depressed. So we have to beg the question, well, if that's not the one singular cause, what are the confluence of factors that are resulting in you feeling depressed? And that's where we want to get to the bottom of this, because it seems like a lot of depressed patients are out there wondering, taking their antidepressants, not feeling pretty dang good. Or maybe, you know, talking to their psychiatrist. This is not a bag on anybody, but it's saying that maybe there are 10 variables underlying this issue of depression. And we're going to talk about the gut today.
And we've kind of gotten to the bottom of it, really. But there are gradients. There are people who are severely depressed. And the damage is there.
That's a great point.
And we do have a functional psychiatrist that we work with when we need, meaning he understands that it isn't a personality disorder. And they do say that in the Mayo Clinic, in this little blurb that they have. It's their page that tries to get that you look for depression for the Mayo Clinic, and then they tell you how to come there and let them give you the medications that they give. And that's what they say on there. I'm not making fun of them. I'm paraphrasing what they say on there. But they do say it's not a personality disorder. That surprised me, because it's not. But there are degrees of it. I'm not cavalierly saying come here, you know, if you've been in, you know, in a deep depression for depression or anything like that. I'm just saying that there are functional causes of it, meaning there are chemical causes, there are neurological causes. Frontal lobe is, as I understand it from the functional neurology world, is kind of when it's not working right, you get depression. But the question is, why is it not working right? Is it not working right because you smashed your left frontal lobe through a windshield when you got in an accident? Or is it not working right because of some of the things we're going to talk about today? And we're going to primarily focus on the gut, because boy, that's where we start all of our cases, pretty much no matter what, if there's a metabolic involvement there, because that's where we get, if you will, the most bang for the buck. That's where once we get through the gut, that's where the most symptoms disappear, and then we kind of sit there and look around and see what's left. But the gut is an evolving thing. Looks like Dr. Gates is going to talk about why the gut is gaining more and more attention today. And so let's go into depression. What is depression? What is depression?
Depression, and I'll read
Overview
this here. Because I didn't feel like memorizing this. This is from the DSM-4, which is the standard manual and textbook that psychiatrists and other physicians use to basically characterize a diagnosis. And depression is a period of 2 weeks or longer during which there is either depressed mood or loss of interest or pleasure, and at least 4 other symptoms that reflect a change in functioning, such as problems with sleep, eating, energy, concentration, and self-image. And with all those, it can go either direction. For example, maybe you're sleeping too much, or maybe you can't sleep. Maybe you have a lot of energy, maybe you don't have enough energy. So that's in essence how depression is diagnosed. And it affects a large segment of the population. We're talking about 7% of the adult population here in the US. It's about, according to this, it's about 16 million adults that are classified as having this.
Classified as it. I mean, in the bottom line is this: if you think you have depression, you probably do. I mean, that's what we have found, that people come in, they feel like they're depressed, they are. But the question I usually ask is, do you feel like you're like it's something that is you, or do you feel like it's something that is you're being affected by something? And most of the time they'll say, I feel like it could go away if I could just, I don't feel like it's me. I don't feel like I'm a depressed person, but I'm depressed. And I think it's really a good, just for you to know out there, if you're feeling that, you go to the doctor and say, well, you're not depressed, and you're feeling it, you may be depressed, and you may want to look further into some sort of, we'll talk about what we might want to look into today.
Absolutely. That's a really good point. Yeah, because a lot of depressed patients, they're not depressed people, but they are depressed.
Right.
And they struggle in that, and it's almost like that quicksand of not knowing why they're feeling that way.
And not being classified.
Right. And I think the whole
and not
purpose of this is
not
just,
getting the
a lot of
treatment.
people, they go through like a tough day and they say, I feel depressed. If you have a bad day and it's one day, you're not depressed. But if it goes on for longer than 2 weeks, that's where it starts to become a depressive issue. And I'm with Dr. Rutherford. It seems, in our experience, pretty dang common. It seems more common than 7% of the adult population.
I mean, it is a rare person who walks in here who does not check off depression on the box in our pre.
And their symptoms are usually pretty consistent with it.
Rare, yeah. So, and you're going to find out why.
And then we have 120 million chronic pain patients. You're saying that. Most of them are depressed.
Most of them are depressed, exactly. Most of them will come in. Look, we treat chronic pain. We've been doing it for years and years and years and years and years. And everybody comes in. I mean, it is, if that box isn't checked, there are just about 4 or 5 boxes where if they're not checked and that person's got chronic pain, I'm going to ask them. And inevitably they'll say, well, maybe I'm depressed, but I'm not sure. My doctor said, but at point being, that's probably all 120 million of those people. So I think it's very common. I think it's confusing. I think it makes people feel bad. I think it makes people feel like they're weak. They're not weak. There are most of the reasons for depression is a wide variety of them are functional. There is something that's not working, and frequently it can be fixed. There are severe cases that require maybe a combination of that type of procedure and maybe some medical procedure, something like that. There are those on a scale of 1 to 10, those 9 and 10 cases, but depression is. I've hardly ever talked to anybody who hasn't experienced it for at least a little while. So anyway, so we go to the Mayo Clinic, and the Mayo Clinic says we don't know exactly what causes it, but we're going to treat it. So how are they going to do that? What are the typical treatments that people experience?
They start with the typical antidepressants, drugs like Prozac, other tricyclic antidepressants. If you fail on those, then you may be bumped up to some of the neuroleptic medications, as they're termed. These are the antipsychotic medications within the class. So drugs like Seroquel can be used in this setting. Mirtazapine. These are more the psychiatric drugs that are used. And then if you fail those routes and you fail psychotherapy, where you're talking to someone about your feelings, they may try electroconvulsive therapy, transcranial magnetic stimulation, where they put a magnet on your frontal lobe, basically trying to get your frontal lobe to work better. The electrical convulsive therapy, they don't really know why it works, but basically they just put a ton of electricity into your brain, hoping that it causes your frontal lobe to work better. And that's really where some of the functional neurological applications have come from, because as Dr. Rutherford said, and we could have gone so many directions with this broadcast. We're just going to focus on the gut. I mean, we could do a whole broadcast on frontal lobe implications and on depression. But in essence, your frontal lobe is in the front part of your brain. There are many different areas of your frontal lobe. Some parts of your frontal lobe help you to move. Other parts help you to move your eyes. Other parts help you to think about how you're going to play a piece of Bach music. And other parts of your frontal lobe help with mood. And so the areas regulating mood, areas of the orbital frontal cortex, I don't need to go into them, can maybe not be functioning as well. Maybe they're a little slower in their metabolic rate. Maybe they don't have enough neurotransmitters in those areas. And so one concept is
chemicals that make your brain work right.
Exactly. One concept is, well, why don't we just exercise that area of your brain? Kind of analogous to putting electricity into your brain or putting a magnet over that area of your brain, causing it to work better. The reason why Dr. Rutherford and I have married our two disciplines is because it's very powerful. Number one, we've seen great results. Number two, and with all of these neurological disorders, usually there's some underlying metabolic cause, and then there's some neurological impairment. And you can fix the underlying metabolic cause, and sometimes the neurological impairment will improve, but it may not improve to the degree which it could if we exercise that area of the brain or activated it more.
Analogous to the electrical treatments that the medical model does.
Exactly. And that, without addressing the metabolic aspect, we feel is an exercise in futility too, because you can help the brain function better. But if this is still constantly pulling the neurological side down.
And the metabolic aspect is analogous to the drug intervention of trying to change your chemistry, but in a much different way. So I don't think you really got off base there. The point was, what was the typical treatments? And the typical treatments are drugs which alter brain function, not in a good way long-term, okay? And electrical stimulations. And many of you may not realize that your brain is an electrical unit and that it fires at a certain frequency. When those frequencies go off, you start having problems. And so Dr. Gates is talking about a little bit of what we do relative to, we use exercises to stimulate those parts of the brain in the same way you would use a weight to exercise this. So the bottom line is this: typical treatments are pretty aggressive. They're mind-altering drugs, not like maybe we used to experience when we were in the 60s. Not me, but mind-altering drugs in the fact that they change the chemistry, and they have significant long-term side effects, or pretty radical stuff, running electrical currents into your brain. Doesn't hurt. Or putting magnets there to try to generally stimulate neurologic electrical function there and get you better. That's what the typical treatments are. And it would be our observation that those are short-term, short-lived treatments, or they're treatments that you got to keep doing for the rest of your life.
Right. Yeah.
Okay.
I mean, most people on antidepressant
I'm looking at
therapy,
you're the brain guy.
Most people on antidepressant therapy are probably going to be on antidepressants for quite some time, unless it's more of an environmental circumstance. You lost a loved one in a couple of years, you're doing pretty well. So
the next thing would be, what would be the other treatments for something like this? What things could be causing your depression? There are alternative treatments for this. You know, I got to tell you, we don't consider ourselves alternative, and probably because of our background, probably because of our educational backgrounds, probably because we deal with this stuff, but we also communicate with medical community on this. So we're kind of not in the club. We're kind of not in the medical club. So people call us alternative, but I don't know that what we do is alternative. I think it really is based on all the science. If you've looked at any of the studies, that the hundreds, or I don't know, by this time, maybe thousands of studies that you've attached to all of our things that we've done, you'll see that, the things that we're saying are pretty well embraced by the scientific community. But let's talk about some of those things as alternative treatments.
Mm-hmm.
What are some of the alternative treatments, since you're the one who put that term down?
So alternative treatments include taking supplements like St. John's wort, taking 5-HTP, which is the precursor to serotonin. St. John's wort basically causes a long-term increase in serotonin in the brain to a certain degree. Taking some dietary supplements like creatine monohydrate, which is used in bodybuilding, which has been shown to increase cellular energy in the brain. Those would be more of the characteristic alternative treatments.
Okay, so you're talking about so when I got into this, these are the kinds of things that we used to do back in the 80s. Was we took the medical model and said, okay, get off of your Xanax, or not your Prozac, but we'll give you St. John's wort or something like that. Exactly. And these, again, they can be effective variably from one patient to the other. They can be totally not effective, but they're not the solution. Is that where you're going?
Yeah, I agree. I mean,
they're not getting to the cause. You can have certain types of depression and take a dopamine neurotransmitter or a serotonin neurotransmitter, which are natural supplements. They're neurotransmitters, you can take them, but they're not the solution.
Right, and we'll use those in a short-term period,
right.
But they're, as you're saying, they're not the solution. They're not the underlying cause. And really, just generally, what are some of these underlying metabolic causes? We've talked about it extensively in other broadcasts. Thyroid is huge relative to depression, not only thyroid hormones. We're talking active thyroid hormones. So go back and watch our thyroid broadcast. We go into that extensively. Hashimoto's thyroiditis, where the immune system is killing the thyroid. The immune inflammation is thought to result in depression in a significant number of subjects. Like 32% of people in facilities for depression have Hashimoto's thyroiditis, which is very significant. Stress. Our beloved Robert Sapolsky, Dr. Robert Sapolsky, who wrote the great book, Why Zebras Don't Get Ulcers, he talks extensively about how chronic stress, chronic elevations in stress hormones like cortisol, will cause your brain not to function as well and for people to feel depressed. He also is a big promoter of Hashimoto's as a cause of depression. And
blood sugar imbalances.
Insulin
and resistance, inflammation.
I wouldn't disagree with that. Yeah, absolutely. And then also autoimmune responses. So they've shown that upwards of half of depressed subjects have antibodies, which are little immune cells that kill things, half of depressed subjects have antibodies to serotonin, which is kind of significant because if you're taking your serotonin medication, your immune system is killing serotonin, that might have some relevance. So those are some of the factors. And today we're going to, root causes. Today we're going to discuss the microbiota, the gut, and its relationship to depression. But those are the topics that we've hit in other broadcasts that you should probably be familiar with if you're suffering with depression and you're not getting better.
So now we're going to go to the gut. And I have celiac.
Yes.
I think celiac is listed as one of the things that can cause depression.
Yeah.
I think they're saying that Crohn's disease can cause it, and ulcerative colitis can cause it. So now we're in the gut. So I know that was a rather long lead-in, but we like you to understand the full framework of everything that you're dealing with, because when somebody, let's say somebody came into us with depression, which almost never happens. In fact, I don't know if anybody's ever walked in here and said, I'm depressed, can you help me? These are all the things we would be looking at. Today, we're going to talk about one of the bigger aspects, though, of what we would look at first if a person came. Well, we'd look at according to their history, but still, we would start in the gut. Almost whatever what it is, we would start in the gut. And so we're going to talk about the gut today. And we're talking more about the small intestines than anything. Yeah. Okay. Yeah. So gut can be a lot of things. We're going to be talking mainly small intestines today. So why? Why are we doing this? How come almost every single time we talk about, no matter what it is, we talk about the gut? How come volumes are being written on the gut? How come I just got a book from Dr. Vasquez on the microbiome and chronic disease? Dr. Vasquez is he's a lot of things. He's got more degrees than anybody I know, but he is focused in on the gut, and he teaches seminars on this, and he teaches at a school on this, and he's pretty far out in front of the group on this. Why the gut? Why is the gut getting all this attention in the literature, in the accepted research? Why is that happening?
That's a great question. Really why it's happening, I think, largely because of functional medicine doctors. That's what I think. I mean, it seemed to start around the early 2000s. Doctors started using diets. By functional medicine, I'll give credit to the naturopaths. The naturopaths have been on this bandwagon forever. It's just the research wasn't there. And then I think around the time that some functional medicine doctors started coming out, they started promoting new research on eliminating things like gluten from the diet. And all of a sudden, people started feeling better. They started losing weight. They started feeling great. Their depression was going away. And then we have celebrities on TV now talking about them having those same experiences. Now we have 100 million people who've gone gluten-free in this last year. And this has prompted researchers to say, well, maybe there is a gut connection to these illnesses, like a lot of autistic patients going off of gluten and dairy and getting some improvements. And so from that, the research community has seen the clinical results, as we've often talked about, and then they create these research studies, and now it's 2015, and now we have about 3 to 5 good years of research looking at the preliminary relationships of the gastrointestinal tract to these disorders, like obesity, like diabetes, like autism, like depression, and I could go on and on and on. So today we're talking about depression. So that's why, in my opinion, the gut is gaining so much ground. And we had talked last week about a podcast I listened to by a gentleman who was in the lab. He didn't discover it himself, but he was working in the lab with the other gentleman who discovered that H. pylori, which is a bacteria in the stomach, causes ulcers. And this gentleman was pretty much laughed out of the room when he said, I think the ulcers are due to a bacteria. Because at that time, everybody thought and knew that ulcers were due to stress. And so he ultimately proved his model. And now that is the accepted model within gastroenterology for treating ulcers. But this gentleman on this podcast said that doctors of the future are going to evaluate the microbiome first. And the microbiome is this collection of bacteria in our intestines. And they are relatively individual to all of us. There are shared relationships.
There's a lot of it.
There's a lot of it.
4 pounds of it.
Yeah.
In your intestines. Think
yes,
about that.
Trillions
4
of
pounds
bacteria.
of bacteria. And we don't know what they all are.
We don't.
And we don't know.
And the information is just coming out. Now the new thing is genetic, basically genetic analysis of the stool. So the problem with these bacteria in the gut is that you can't grow them in a petri dish because they grow in an environment without oxygen. And so now, because of this, they're using genetic sequencing of these bacteria. So they can say, well, this bacteria has this type of genetics and this bacteria has this type of genetics. So they can kind of profile and see there's a lot of this type of bacteria and not very much of this bacteria. I smiled when I said that because Dr. Rutherford and I used to use a genetic analysis of the stool that then was bought by another company and they stopped using it.
and they stopped using it because the insurance companies wouldn't pay for the test.
Right. And they were discovering a lot of
phenomenal
parasites.
test. So now it doesn't exist.
And it got a lot of people up in a ruckus. So that's why I smiled. But we're not smiling about depression because we'll get comments on that. We're not smiling.
So how does this all play into depression? So how does so we have is treating the gut the new frontier in antidepressant therapy? And I would argue that it is. I would argue that we've seen it every day. Frequently, by the time when we start treating patients' metabolic and biochemical pathways, truly the first things that seem to lift seem to be if a person has brain fog, short-term memory loss, and depression seem to start lifting fairly quickly. Mm-hmm. And we start our logarithm of treating the nutritional aspects and the chemical aspects of a chronic pain case. We always start with figuring out what's going on in their gut and how to treat that first. And so why don't you share with these folks the pathways of this bacteria leading to them having depression?
Okay. So the general framework that you need to understand anatomically is that there's communication between our brain and our gut and our gut and our brain. The way that happens is that we have something called an autonomic nervous system. Think of it as an automatic nervous system. That is either in two gears. One gear is fight, flight. So you see the grizzly bear. The other gear is rest and digest. You're laying on the beach in Maui. And that autonomic nervous system sends signals to our gut to something called the enteric nervous system. Enteric just means gut. So think of it as the gut nervous system. As Dr. Rutherford said, in the East, they've been saying the gut is the second brain. And now in the literature, they're referring to the gut as the second brain as well, because this enteric nervous system is like a brain unto itself. It has a lot of connections. It's actually pretty dense with neurological synapses or connections and so on and so forth. The way the bacteria in the gut affect this is such that the bacteria in the intestines, which are surrounded by this gut nervous system, and the bacteria can produce byproducts that can actually cause this gut nervous system to see what's going on. So the gut byproducts actually act as like transmitters or activating chemicals for this gut nervous system. And then this gut nervous system can talk to the autonomic nervous system, like I was talking about, the automatic nervous system. Specifically, one is called the vagus nerve. Most of you have heard of the vagus nerve. And the vagus,
probably not.
You don't think so? Seems like a lot of people have a lot of awareness of the vagus
nerve.
Okay. Okay. So the vagus nerve is a big nerve. It's a huge nerve that basically goes from the brain to the gut and sends signals from the gut to the brain. And now the vagus nerve can send these signals up to the bottom part of the brainstem, to a specific area I won't mention to you because it doesn't matter to you. And then that can tell the brain what's going on in the gut. And so they're finding that bacteria down here in the gut are really influencing how the brain is functioning. Even more specifically now, they're finding that they can give mice, for example, probiotics, and then they see that receptors in the brain for chemicals that shut off anxiety increase. Pretty wild. And now these studies are now coming out regarding use of probiotics in humans as well as mice, improving mood, improving emotional center activation within the brain, so positive emotions, lowering cortisol as one of them.
Stress hormones.
So it's pretty profound. Dr. Rutherford and I always chuckle because a lot of these studies, everybody once they figure out that the gut has a relationship to the brain or to some other part of the body, they want one simple solution, and that is the probiotic.
I knew you were going to say.
And so we're going to give them probiotics because it's just like giving them a drug, and that's simple, and we'll get them out of the office in 5 minutes. Unfortunately, these relationships are a little more complicated. And they have also shown that in depressed subjects that they have different bacteria in their intestines than non-depressed subjects. And they've also shown that those bacterial imbalances in depressed patients can be altered with dietary interventions. So certain diets increase good bacteria, other diets increase bad bacteria associated with depression. So that's a pretty profound finding. And that's really congruent with our clinical practice, because we use definitely certain diets with certain patients. We have one baseline diet, and we have 5 other diets that we use as modifications of that baseline diet.
Right. You might be exposed to the GAPS diet, or you might be exposed to the specific carbohydrate diet, or you might try what's the paleo diet or whatever it is. And none of those diets work for everybody, but different of those diets. Imagine you have 4 pounds of bacteria in your gut, and in the people whose guts are affecting brain function, theirs is imbalanced, and it's imbalanced significantly toward them having much more bad bacteria than good bacteria. And so, and a lot of those bacteria, you don't even know what they are yet. So there can be different bacteria that are overwhelming different people. And so the same diet doesn't work for everyone. There is no one diet out there, as we have found. If you go to your practitioner and say, try this diet, it doesn't work, that's hard. You have to have a better feel for what's going on in that person's intestine. Do they have H. pylori? Do they have parasites? Do they have celiac? Do they have gluten sensitivity? All of these aspects of a gut and more influence the chemistry that Dr. Gates is talking about, and that will ultimately alter the chemistry in your frontal lobes, and if your frontal lobes have altered chemistry, lots of bad things can happen, and one of the most common ones that can happen is depression. So diets are profoundly implicated in the alternative treatment. I'm not sure if diet is an alternative thing. We all eat, but I get it. But diets, but they have to be very, very specifically fine-tuned to that person. Food sensitivities relative to the diets also are significant. And as you can guess from food sensitivities, you have 10 people in the room, and all 10 of them might have different food sensitivities. So that makes their specific diet unique. So basically things get out of your intestines, and they get into your bloodstream, or they are transmitted in other ways up to your brain. And now you alter the chemistry there, and because of what happened in your gut, and now you have depression. And it's really...
Yeah, and in the models and the research, they're looking at it, they're trying, because researchers don't necessarily work in our type of environment. So researchers are saying, okay, so we see this, just as I described it, because I try to present the current research, and then we kind of try to bring in our clinical experience. But the research is saying, okay, so these bacteria produce byproducts, those byproducts go into the gut nervous system. The gut nervous system talks to the vagus nerve that goes to the brain, and that's probably how this is happening. And then they cite research articles where they give probiotics, and everything I just said, people feel better, their mood goes up, they have less anxiety, less cortisol, on and on and on. Those relationships are demonstrated. Now, there's also relationships that I didn't even attach to this article regarding leaky gut syndrome, as Dr. Rutherford was saying. And so, you know, leaky gut syndrome is pivotal. And so that's where the gut barrier breaks down. I know you explained this already, but I just want to perseverate on it. So the gut barrier breaks down, then pieces of bacteria can break in. That can result in systemic immune activation, and that can go into the brain and affect the brain. And possibly by giving people probiotics, you're improving the leaky gut to a certain degree. But those relationships are not out there, because this is a new frontier as we're talking about it.
Right.
And
like
we're seeing
psychobiotics.
Right. And so now, rather than calling them probiotics, they're calling them psychobiotics. So they want to give you probiotics and say it's a psychotherapy.
Marketing,
and it is.
marketing.
Right. It is marketing. And it's going to be used to sell you more probiotics. And probiotics are not bad. We're not saying they're bad, but they're just one piece of this complicated puzzle. And, you know, I attached research articles regarding IBS. So irritable bowel syndrome is a condition where people get bloating, constipation, diarrhea, you know, uncomfortable feelings in their abdomen after they eat. has to have been there for a certain length of time, but they know that there's a high association with depression and anxiety with IBS, but they've also seen that IBS can be associated, from the flip side. So depression and anxiety is associated with IBS, and IBS is associated with depression and anxiety. And lack of bacterial diversity in the gut is associated with anxiety by itself. So there are these reciprocal relationships. They're now calling it the gut microbiota brain axis, and it's a two-way street. They refer to it as bidirectional communication. So the gut's affecting the brain's affecting the gut.
So basically, if you have depression and you have gut problems, you have symptoms, and I'm not wrapping this up, but if you have symptoms, but I mean, for example, I have celiac. I was surprised to find that by getting off of gluten, and you can look up our thing on celiac, but gluten causes an immune response in the tissues in your gut. By getting off of gluten, my brain function, got better. And if you have Crohn's disease, if you have ulcerative colitis, if you have irritable bowel syndrome, if you have any of those things, that really needs to be dealt with in an effective way. And then that will dampen the response. And now maybe you don't need the Prozac, or maybe you don't need the St. John's wort. Frankly, maybe usually goes out the window at that point in time. Usually at that point, you're not going to need it because the chemistry is going to be right. Their medical profession is onto this, and they're not completely dissing this by any means, but they're going about it. And kind of what I say is a lot of times what will happen in this model of care, in the medical model of care, is you'll be like shooting a mouse with an elephant gun. And I kind of put fecal implants in that category, but there seems to be in the medical profession a push for fecal implants, putting feces from a healthy individual's gut. Good luck in finding them.
Right, 1 in 5,000.
and into your gut and seeing.
Who's doing that research? You got that crappy job.
Yeah, exactly.
I'm trying to find the right feces out of these 5,000 samples.
But when they do find the right feces, the person feels better. Right. Why don't you talk about fecal?
Yeah, fecal transplants. It's along the same line where now we know the gut affects all these conditions. So people are talking about probiotics. There's a lot of excitement about fecal transplants because they did it in mice relative to obesity. So you have a fat mouse, you have a skinny mouse, you take the poop out of a skinny mouse, you put it in a fat mouse, all of a sudden the fat mouse loses weight. And if the fat mouse goes back to its bad dietary habits of eating like an American diet, lots of saturated fat, lots of processed carbs, the fat mouse gets fat again. So from that, they've started studying humans. As Dr. Rutherford and I were laughing about, kind of an inside joke we had talked about on one of our Saturday morning breakfasts, that he had come across research showing that only 1 in 5,000 stool samples are sufficient for changing the microbial diversity in the intestines. Only 1 in 5,000 people actually have good bacteria in their gut. And so that's now being discussed as a mainline therapy for things like depression in the literature. And maybe that will be utilized in 10 years. Maybe, maybe not. We don't know at this point. But again, it's along the same thought process of one thing for one condition, which is why we have 120 million chronic pain patients and however many million depressed subjects, and we have a very sick population. And that's what we're trying to convey to you in these broadcasts. You talked about gluten. We're now knowing that there's this thing called non-celiac gluten sensitivity. So you don't have to have celiac disease where you have an autoimmune issue to gluten and it's killing your intestines. 10% of the population now is reporting that when they eat gluten, they feel worse. And you're seeing a lot of negative stigma in the media regarding gluten. Gluten sensitivity isn't real. That literally there are articles coming out stating that because they did one study where they showed that people who thought they had gluten sensitivity ate gluten, and that by itself didn't cause their gastrointestinal symptoms to be worse. But they didn't attach the study, which basically showed when these gluten-sensitive people ate gluten, they were depressed. And you'd have to argue, how are they depressed? Really, there's a neurological implication to eating gluten for these people. And one of the key things that's now being shown for those who are gluten sensitive is that gluten causes leaky gut syndrome in those who are gluten sensitive, and possibly by these bacterial relationships we're discussing today, that's resulting in the gut nervous system getting activated with inflammation, and therefore your brain having all of the consequences we've discussed.
Yeah, so our experience is it's a little complex. When I say you need to look to your gut first, then you also need to, not to sound self-aggrandizing, but you need to find somebody out there who's either doing, usually it's going to be somebody who's doing functional medicine, who understands the gut and what to look for. On that one test that we were talking about that is no longer in existence, they evaluated all the microbiota, they evaluated the different types of bacteria that were known DNA-wise. They evaluated H. pylori, they evaluated whether people had parasites in there. There's another test out there from Cyrex Labs that evaluates whether you have intestinal permeability or not. You kind of need a neurological evaluation too to determine whether these stress mechanisms are engaged. And when we say stress, we're not meaning that you are a stressed human being or can't deal with stress. We're talking about that nervous system that Dr. Gates called the automatic nervous system. And basically, we're designed to be relaxed like almost all the time. And when we get stressed because there's a fear or there's some challenge that we have to meet, or the primitive reflex is anecdotally to fight the bear or flee from the bear, that's a survival mechanism that's only supposed to be engaged for a short period of time. Most of our patients have it engaged when they get here all the time. It never shuts down. And if that's not shutting down, it's flooding your system with stress hormones. It's doing a lot of things to your brain, but it's doing as much, if not even more, to your gut. It damages your gut. That causes the brain problem. So it's a complex situation, but if you understand the functional perspective of it and that all these things are effective, when the patient comes in, you look for them all at once. Not everybody, not everybody has all of them by any means, but this person's got 2 of them. This person's got 3 of them. This person's got 1 of them. This person's got 6 of them. Now you know what you're dealing with, and then you can attack the gut from that perspective and see what happens. And most of the time, you're going to get a positive result. And so that's been my experience with that data. I don't know, if you want to share anything different than that.
I think you summarized it perfectly.
Yeah. So, and we have for those of you who may have just looked this up, or may just look this up in the future, or some of you who just joined this morning for the first time. By now, I think we have probably 125 or 130 or 140 hours on. A lot of it is dedicated specifically to gut function, irritable bowel syndrome, celiac. You can look up any of those. And we discuss these mechanisms within the framework of that. We discuss how we diagnose those and how they're treated by us. And, probably a lot of functional medicine doctors out there. So, so depression is treating the gut, a new frontier in antidepressant therapy. Not for us, not for us. It's not, but it is a new frontier in the research, and that is encouraging. It's coming up with the fecal implants, and it's coming up with vitamin companies now selling psychobiotics, and there's just so much marketing out there, and it's a little discouraging. But yeah, it is a new frontier. The research out there on it is ramping up dramatically. It's probably going to come up with more drugs. It's probably going to come up with more probiotics. It's probably going to come up with more fecal implants. But it doesn't have to be that exotic to get better. And diet plays a huge part of it. And then handling whatever other things are going on in the gut, is kind of the rest of it. Finding out, well, that's pretty much it right there. So that's it. Yes, it's a new frontier. I think we've covered it pretty clearly. I think we'll probably close this segment out and come up with another subject for next week, 3 minutes before we're ready to do a presentation. And which is kind of how it happened today. All right, 40 minutes before, 40 minutes.
It's an hour
before we're going to make the presentation.
Needless to say that 2 hours last night I spent researching, trying to figure out what we talk about today,
what we talk about. Because
we definitely have talked about a lot. And so that's where it's becoming more interesting. We've been doing a series on autoimmune diseases in the gut. I just felt like we needed a break from that. And so that's why I went this direction. But
so if you want any more information relative to anything that we've talked about, You can look us up on powerhealthtalk.com. If you're interested in our other presentations, you just scroll down to Hangouts, and you can just review them all and see what interests
And you can go
you.
on YouTube, which will then direct you to our page too. We have a lot of snippets, short videos on YouTube.
We're still on Facebook.
We're on Facebook, yeah.
We're on Facebook. I don't know how to do Facebook, but we're on it.
We're on Facebook.
So, okay, so we will see you. Many of you we will see next week. Some of you we will hear from during the week, I'm sure, and we'll try to come up with something interesting for you next week.
Thanks for watching.